the NADH converting to NADA, and FADH converting to FAD. These electrons are transported to the complex 3 and the 4, and this complex 3 and 4 in a momental way transport electron into the complex. This is the blue, the complex 4, the blue one, and where the ATP actually form. So there is actually work, the mitochondria में जो काम हो रहा है वो behind the scene बहुत काम हो रहा है, and the complex 5 uses the proton gradients as the driving force for the generation of this ATPs. But with this, when there is during this process of electron transport, some of the electron leaked. जैसे अब यहाँ से कुछ लोग अभी बाहर चले जाएंगे, so these और जाके बाहर शोर मचाएंगे और बाहर जो है वो खड़े हो जाएंगे. इसी तरह कुछ लीक हो जाते हैं जो ट्रांसपोर्ट इलेक्ट्रॉन, और वो प्रोड्यूस करते हैं रॉस. रॉस इज द रिएक्टिव ऑक्सीजन स्पीशीज, और जहाँ पर भी रॉस है वहाँ शोर शराबा और बर्बादी है. सो वो इन्फ्लेमेशन के लिए मुसीबत वो कॉज करते हैं. एंड दिस रॉस are produced, and we will discuss why these ROS are important. And then if these ROS part, when there is decreased ATP production in any cell, कोई भी cell हो, अगर ATP production उसकी कम हो जाएगी, so वहाँ ROS की production ज़्यादा होना शुरू हो जाती है. And this ROS production and can open the pores, and you can see this structure on the right side of the screen, the blue one. These are actually the MPT. These are the pores where the apoptosis can begin from here. So the opening of this channel can bring up the apoptosis. So this is the background why. So not only the ATP, my dear friends and colleagues, which is produced by the mitochondria, but they are also the prime regulator of the apoptosis, and which is the natural cell death. And the oversupply of the calories and the physical inactivity can impair the transfer of this electron through the electron transport chain, leading to increased production of ROS. And these tissues include the beta cell, the muscle, and the mitochondria. So the three major functions of the mitochondria: the ATP production, generation of ROS, and apoptosis. So the mitochondrial dysfunction in diabetes. So this is very recently in 90s that the mitochondrial dysfunction was shown to be an etiological factor for the diabetes. And there are in 90s and early 90s a specific mutation in mitochondrial DNA was identified to cause related to the maternal inherited form of diabetes. And the peripheral mitochondrial DNA copy numbers were decreased in subject with type 2 diabetes even before the development of type 2 or the onset of type 2 diabetes. And the oxidative phosphorylation was also decreased in insulin resistance offspring of type 2 diabetes. I'm just showing I'm not going into the detail, but this is the work which is done before, two decades before, and published in diabetes care, the beta cell dysfunction. And what is the chronic hyperglycemia due to the beta cell dysfunction, and what is the role of the mitochondria in this connection. And then there are a number of papers regarding the mitochondrial metabolism and the diabetes and their function, and what are the bioenergetic mechanism behind it. And the relationship between the mitochondrial dysfunction and the type 2 diabetes, you can see there are many genetic and environmental factors in development of diabetes. The mitochondrial DNA mutation, the nuclear DNA mutation, and the common genetic variant, and the environmental factor, the obesity and the intrauterine malnutrition and environmental pollution, all causes the mitochondrial dysfunction. And that they led to the beta cell dysfunction and insulin resistance, and then this has caused the type 2 diabetes. So the mitochondrial dysfunction, and there are reports that the pathological, what are the different mechanisms of the mitochondrial dysfunction in relation to the causing the insulin resistance. I'm not again going into the detail, but there was a paper which showing that the impaired mitochondrial activity in insulin resistance offspring of patients with type 2 diabetes, and the conclusion that the data support the hypothesis that the insulin resistance in the skeletal muscle of the insulin resistance offspring of patients with type 2 diabetes is associated with the dysregulation of intramyocellular fatty acid metabolism, possibly because of inherited defect in the mitochondrial oxidative phosphorylation. And the role of the mitochondria, we all know that how it regulates the glucose dependent release of insulin from the beta cells. So mitochondria actually regulate the glucose stimulated release of insulin from the beta cells. And there are papers which shows that the mitochondria reactive species generation in obese non-diabetic as well as in type 2 diabetic patient. The cells, in the beta cells, if you have decreased ATP generation, there are increased reactive oxygen production. And so in nutshell, so time जो है वो 2 minute रह गए. So in nutshell, the mitochondria, there is a polymerization, overloaded free fatty acid, and a hyperglycemia increases the ROS, and this lead to mutation, increased mutation, mitochondrial biogenesis, aging, and mitochondrial dysfunction. And this mitochondrial dysfunction is actually causes the beta cell oxidation, decreased beta cell oxidation, beta oxidation, ROS formation, and decreased ATP generation. So diabetes core defects, we all know, as the Asghar has defined them very well. So when not going into the detail, but there are 8 number there, but still there are 2 core defects in diabetes which are prominent in everyone, the insulin deficiency and the insulin resistance. So the ideal anti-diabetic drug which is claimed to be, which correct both insulin secretion defect and insulin sensitivity. But my dear friends and colleagues, no two identical twins shares many things but not everything. So identical twins can share many things but not the everything. So the imeglimin is like metformin. It is like it's sharing but it is different from the metformin as well. And this is very latest paper which is in 2024, that the differential effect of imeglimin compared with the metformin on insulin and incretin secretion. And you can see over here the area under the curve of insulin was significantly increased only in the imeglimin as compared to the metformin. And this is how the imeglimin actually works. So the imeglimin is decreasing the partial inhibition of the complex 1, which produces which transport the electron, and then it also restore the function of the complex 2, and this leading to decrease in the formation of reactive oxygen species. So the imeglimin decreases the ROS formation, and also it having the inhibitive effect on MPTP, which initiate the apoptosis. So it also closes these spores and therefore decreasing the cellular apoptosis as well. And so restoring the complex 2 activity and inhibit complex 1 activity and decreasing ROS production by the imeglimin. And the imeglimin molecular mechanism, which improve glucose homeostasis, it increases the insulin sensitivity, decreasing the oxidative stress, decreases the gluconeogenesis, increases the beta cell function, and increases the mitochondrial function. So how did the drug develop over the period of time? In the animal studies, the imeglimin normalized the glucose tolerance and insulin sensitivity and improved mitochondrial function in liver of the high-fat, high-sucrose diet in mice model. And imeglimin is increasing the glucose-stimulated insulin secretion and reduces the glucose in vitro in high-fat rats. So the imeglimin increases the insulin secretion and increases the insulin sensitivity. But in the human studies, there are three, the trial of imeglimin for efficacy and safety. The TIMES study, and there are 3 time studies. I'm sharing just a single word, this efficacy and the safety of imeglimin in monotherapy versus placebo in Japanese patient. This is a double-blind study, randomized placebo-controlled study in the multi-center. And you can see over here, the imeglimin decreases the HbA1c up to 0.87, which is a statistically significant HbA1c reduction in the people with in type 2 diabetes. And HbA1c reduction with the, in comparison with the placebo. And it also decreases the fasting blood glucose production about 5.5 milligram per TL. And with a comparable side effect with the placebo. So literally about minimal GI side effects as compared to the metformin. And this is the edge of imeglimin on the metformin, that it has got a less side effect on the GI. And the long-term safety and efficacy of imeglimin as a monotherapy in combination with existing antidiabetic in Japanese type. This is the times 2 52. So मुख्तलिफ जो अभी अवेलेबल आपके पास ट्रीटमेंट है उनके साथ कॉम्बिनेशन में you can see when combined with the DPP-4, it decreases the HbA1c of 0.92. When combined with the bigonides, decrease the HbA1c of 6.7. And when combined with the sulfonylurea, it decreases the HbA1c of 0.567. And lastly, the phase 3 trial, when in combination with the insulin, you can combine the imeglimin with the insulin as well. And the efficacy, you can see the reduction in HbA1c. The people who are only taking insulin, you can combine with the imeglimin and the HbA1c reduction, a further reduction in 0.6% in the HbA1c in type 2 diabetes. So, and my dear friends, the last 2 slides, the imeglimin had, it was shown that the mitochondrial function is lower in the mitochondrium with the LV dysfunction, which is the characteristic feature of the diabetic cardiomyopathy. And there's a whole of a mechanism behind it. I'm not going into discuss this, but you can see it can improve. This molecule may have some other property as well, and we have some data about the cardiac activity as well. So it may have what is beyond reputations, the imeglimin. So my dear friends and colleagues, thank you very much for your patience.
सर बस एक दो अनाउंसमेंट्स हैं. पोस्टर प्रेजेंटेशन इंशाल्लाह 12:30 बजे होगी. उसकी कमेटी में प्रोफेसर डॉक्टर मसरूर काजी, प्रोफेसर डॉक्टर आमिर शौकत साहब, डॉक्टर रियासत अली फ्रॉम कराची PCDA और डॉक्टर शाहिद फ्रॉम कराची PCDA. ठीक है जी, ये पोस्टर प्रेजेंटेशन की कंपटीशन का चीज़ें एनालाइज करेंगे. जिन लोगों के पोस्टर्स हैं वो 12 बजे अपने पोस्टर्स के पास पहुंच जाएं. थैंक यू वेरी मच. दूसरी अनाउंसमेंट है कि अभी एक्सपर्ट पैनल में से हम 1 मिनट की ओपिनियन ले लेंगे सारे प्रोफेसर डॉक्टर जमाल जफ़र साहब की.
I would request Professor Dr. Jamal Zafar to kindly conclude the session with your expert opinion.
Assalamu alaikum. Bismillahir Rahmanir Rahim. All lectures are excellent. First lecture was after Dr. Aftab Mohsin. He has mentioned about the management of diabetes in resource limited society. And we are really, as Dr. Ali Asghar mentioned, that our people are lying below the line of poverty. 40% people are lying below the line of poverty. So we do need to address those issues, and then we should address every patient according to his socioeconomic condition and his environment. And I think I beg to differ with Dr. Aftab Mohsin that sulfonylurea is out. We still need to use sulfonylureas for management of diabetes, although it is complicated with hypoglycemia in certain situations, but if you use it smartly, you can use it and without much hypoglycemia. Qazi Masroor has taken a long time, and I think he has discussed good about all complication of diabetes, kidney disease, and about phenylalanine. This is the latest molecule which is being used along with all the other things in management of chronic kidney disease, in diabetes mellitus. But do you see that there are a lot of complication now? The time has come after 20 years of seeing the diabetes. Now we do see a lot of complications of diabetes mellitus in the form of diabetic foot, in the form of diabetic kidney disease, and lot of patients are going on dialysis. And in Rawalpindi, Islamabad, the poor people are really in trouble that they need dialysis, but they don't have the facilities, they don't have the money, and they don't can go for the dialysis, and finally end up. And then Ali Asghar, as always, he is a very, very good presenter, and he has made his case for triple combination of drugs in type 2 diabetes mellitus. And Zahid Miyan, our friend, he has given an excellent thought. I think this Imeglimin is going to be marketed very soon in Pakistan also. It will replace maybe metformin, but definitely the poor patient, it will be a costly drug. And so for poor patient, मेरे जैसे गरीबों के लिए metformin मेरा ख्याल है फिर भी चलेगी, चाहे with side effects. But for those people who can afford it, probably this will be the best drug. Thank you very much. Thank you very much, sir.
Akmal Sharif and Professor Maqsood Ahmed Saab for shield distribution, please. Professor Dr. Akmal Sharif and Professor Dr. Maqsood Ahmed Saab. I would request Professor Dr. Qazi Masroor Saab to kindly have his shield of honor from Professor Dr. Akmal Sharif. Professor Dr. Qazi Masroor. No, sir. I would request Professor Dr. Ali Asghar to kindly receive his shield of honor. Thank you, sir. Now, Professor Dr. Ali Asghar, he will be having two shields, one from the Horizon Pharma and one from the society. I would request Professor Dr. Zahid Miyan, he will be also having two shields, one from the organizers and one from the Horizon Pharma. Professor Dr. Zahid Miyan Sahab will be having his shield of honor. Thank you, sir. With this, we conclude our first scientific session. Now, I will request Professor Dr. Muhammad Irfan to start the second session. Dr. Muhammad Irfan, if you can hear me. Sorry.
Bismillahirrahmanirrahim. please be seated so we can start our next session. During this session, there will be a lucky draw, and one lucky doctor will get the laptop. During this session, there will be a lucky draw, and it is sponsored by the CCL, particularly their product Gabalin CR. Shall we start our session? First, I request the chairperson of this session. The first chairperson of this session is Professor Dr. Maqsood Ahmed. He is the head of department medicine, DHQ Hospital, Faisalabad. I request Professor Dr. Maqsood Ahmed, sir, please take your seat on the stage. Our second chairperson is Professor Dr. Tariq Wasim. I request Professor Dr. Tariq Wasim, please sir, take seat on them. Our third chairperson is Professor Dr. Muhammad Shafiq, who is head of department cardiology PIMS. Professor Dr. Muhammad Shafiq. And next is the Professor Dr. Mirza Akmal Sharif Sahab. I request Mirza Akmal Sharif Sahab, sir, please take your seat. He is the head of medicine department and professor of medicine in the University Medical and Dental Hospital, Faisalabad. Next chairperson is Dr. IRF, who is the president Pakistan Medical Association, Faisalabad. He is also an assistant professor of medicine in the Allied Hospital, Faisalabad. So without our delay, we start our first presentation. Our first speaker is from the Quetta. He is the professor of medicine, Boulogne Medical College, and he also headed the medicine department, particularly the medical unit 2 in the Sadoman Professional Hospital, Quetta. I request Professor Dr. Jahzeb Khan, sir, please come and give your talk on a very important topic of expanding horizon for holistic type 2 management